All right, so let's continue our conversation around hypokalemia. And then we'll come back, as we had been doing, to the overall algorithm to approaching hypokalemia as we talk about the individual causes. So I'll remind you where we are now. We have gone through cases of hypokalemia from transcellular shift, cases of hypokalemia from non-renal losses. We're now in the renal loss branch of the hypokalemia differential diagnosis tree. And we are talking about patients with alkalosis, right? And then we're going to parse, just to anticipate where we're going, the hypokalemic alkalotic hypertensive patients, right? These are in large part from mineralocorticoid excess. And then the normotensive and somewhat hypotensive patients. So these are the Gittlemans and the Barters. We've already finished Barters. Let's move on to Gittlemans now. Okay. So these are all patients that are going to have high urinary K to creatinine ratios as evidence of renal K losses. Okay. I'll point you to two out-of-date statements that are now updated in the most up-to-date version of the field guide. There is a statement here that I need you to correct in your version, if you have the older version, that genetic testing is not something that is relied upon for making Barter's and Gittleman's diagnoses. That is not true anymore. With the widespread use of Natera testing, these are both captured. All of the Barter's and Gittleman's mutations essentially are captured in Natera testing. Okay, so please update that in your field guide copies. Let's then move on to Gittleman's. And let me get organized so that I can move more quickly. So I have to split my screen, if you'll just bear with me for a second. Very good. And then here I have my nephron figures where I can go back and forth quickly to them. There we go. All right, so we're in the distal convoluted tubule. Let's review where we are visually once again. So when you look at your tubular transport map chapter, here we are in the distal convoluted tubule. The most common defect in a Gittleman's patient is with sodium chloride cotransporter. This is your apical membrane transporter that transports sodium and chloride across the apical membrane. I've already highlighted how there is a bit of a blurring of the line between Barter's and Gittleman's in real life. I mentioned, for instance, that the chaperone protein MAGE-D2 has been described both in Barter's as well as Gittleman's. So here it is in the thick ascending limb. Here we are in the distal convoluted tubule. And then we ended on the concept, if I recall, that urinary calcium excretion rates are not a perfect tool to discriminate between Barter's and Gittleman's in real life, although it is in the textbook the way you discriminate between the two. Now, I'll highlight at least one more. So unlike Barter's, where there's a multiplicity of mutations that describes the Barter's syndrome, where you can have apical membrane transport defects, basolateral membrane transport defects, which we reviewed. Gittleman's is a much smaller set. Most patients are going to have mutations in NCC. That is the most common mutation, causal mutation. But you can also have a basolateral chloride defect in CLCKB that results in a Gittleman's phenotype. Okay, and we have a patient who just came to renal clinic not too long ago as a transfer from Children's. I mentioned him already. He was given the label of Barter syndrome without genotyping, and he had only unilateral hearing loss, which didn't make sense for it to be a Barter syndrome if it's unilateral hearing loss. We reviewed how a Barton mutation can cause hearing loss plus the renal K wasting in Barter syndrome. He did not have a Barton mutation. He ended up having a mutation in only one of the two relevant chloride channels, and that can manifest as primarily as a Gittleman syndrome, as you can see here, okay? Notice that a Barton mutation would also affect distal convoluted tubule transport. I'll just make that point. Again, blurring the lines between Gittleman's phenotypes and Barter's phenotypes. The genotype-phenotype correlation is not always perfect. Okay, so let's go through some of the clinical presentation and then on to treatment. These patients will have the characteristic K wasting. I mentioned to you last time, although you may never see a Barter's patient, you will see Gittleman's patients as a practicing nephrologist. This is not a very uncommon clinical problem. There is some hypotheses out there that the relatively normal blood pressure of Gittleman's might in some way confer survival advantage and therefore have enriched, it's a protection against hypertension and sort of increases the fertility, the length of fertility of this patient population that has mutations in NCC. Some people have also shown that certain people who have only one mutant NCC transporter have a milder phenotype, right? Slightly lower blood pressures. Some have documented slightly lower blood potassium levels. So it is traditionally thought of as an autosomal recessive mutation or disorder. So you have to have both genes for NCC affected in order to manifest disease. But it has been described that even with a single mutation, there is a milder phenotype that can manifest. A little bit of a low K, slightly lower blood pressures. Again, perhaps explaining why this is not so rare, okay? Because there maybe is a protective effect of having being a heterozygous carrier, and then you're more likely to get to heterozygous, have a kid with both genes knocked out then. Okay, so the hypocalciuria is the characteristic distinguishing factor between Gittleman's phenotype and Barter's. We've already gone over that fact. And then I've highlighted how magnesium deficiency, even though it doesn't make sense, is more sustained or more severe in Gittleman's patients than in Barter's patients. Why does it not make sense? We'll talk about this when we get into magnesium homeostasis, but it doesn't make sense because the thick ascending limb is where the bulk of magnesium transport occurs. Okay, so most of magnesium reabsorption happens in the thick ascending limb. And so one would predict then that if he had a Barter's phenotype, a Barter's mutation, that I should have profound magnesium deficiency or wasting. But the reality is that hypomagnesemia is more consistently found and typically more severe in Gittleman's patients. The explanation for that may be that the defect in thick ascending limb transport of magnesium may be compensated for by an upregulation of DCT transport of magnesium. Okay, this is where fine-tuning of magnesium handling occurs. We'll talk about that as we discuss magnesium disorders. There are a whole lot of magnesium disorders that become apparent that are grounded in the DCT. We'll talk about defects in apical transporters, basolateral transporters, this gamma subunit of sodium potassium ATPase is also a potential explanation for magnesium wasting. So again, the take home that I want you to digest is magnesium deficiency is more severe and more common, consistent in Gittleman syndrome, okay? Even though it doesn't intuitively make sense. All right, so we've talked about pathophysiology really being grounded around NCC. I don't need to belabor that. Why the magnesium wasting occurs with defects in NCC is not well described. There are animal models in which NCC is knocked out, and these animal models manifest reduced expression of this apical transporter of TRPM6. Why does that happen? What are the intermediates that link NCC activity to TRPM6 expression and activity? Are not well described. There is a JCI paper that shows some autocrine signaling that is happening in the distal convoluted tubule, but it's not a very elegant story, I would say, a simple, elegant explanation. Just realize that there is reduced magnesium transport in the distal convoluted tubule when you treat with thiazide diuretics or when you have an NCC mutation like in Gittleman syndrome. Genetic testing, once again, correct this. It is readily available. Natera test captures NCC mutations now, so please correct that in your version of the field guide. There will be a updated version that's coming out here shortly. Treatment is usually pretty hard, right? It is, these patients are often on massive doses of potassium, as well as magnesium supplementation. Magnesium supplementation often is limited by GI, by diarrhea. So these are patients that are not easy to treat. We often try and limit the potassium wastage by giving these patients potassium-sparing diuretics. Okay, and so that can help reduce the amount of potassium supplement. But just to give you an insight about how much potassium these patients are taking, often they're taking almost 200 millimoles of potassium a day. So most of these patients are on more than 100, somewhere between, the mid 100s millimoles of potassium per day. So not a small amount. Magnesium is also like TID doses of magnesium oxide. Again, potassium-sparing diuretics are a tool to try and limit the K and magnesium wasting. Now we have evidence that sodium glucose cotransport inhibitors, SGLT2 inhibitors, have a effect on reducing magnesium wastage. So you can use that as a tool. Now, exactly how that will pan out is not well described yet. We know that SGLT2 inhibitors reduce magnesium wasting. They do increase urinary K excretion, though. So we have a recent patient that we started an SGLT2 inhibitor. I'll let you know whether his potassium supplements went down or up. This could, in summary, help with the magnesium wastage, but SGLT2s do increase potassium wastage. So we may not actually help the guy in reducing his pill burden. We shall see. Some people have espoused, because patients may have huge potassium wastage, that treating these patients with nonsteroidals might help. This is used more in the pediatric literature, I would say, where, again, medication compliance in a kid trying to take all this potassium is especially hard, and their kidneys are more resilient. The use of nonsteroidals will have an anti-natriuretic effect, right? These are natriuretic disorders. If you have anti-natriuretic effects, that would reduce the amount of sodium and potassium wastage, okay? That would also downregulate aldosterone. You recall from our conversation on hyperkalemia, nonsteroidals are a cause of hyperkalemia, causing low renin, low aldo, right? All right, let's then move to magnesium deficiency as another cause of urinary magnesium wasting before we go on to these hypertensive disorders of K wasting. Magnesium, I already alluded to its effect. I'll just reinforce it once more, has the effect of gating the potassium channels in the distal nephron. We've gone over ROM-K as well as maxi-K channels as your pathways of K secretion in the collecting duct. Here we are again. You can see maxi-K or big K, ROM-K here as well. We have our magnesium, intracellular magnesium cation, which actually physically plugs the K channel, right? It actually impedes transport of other cations by essentially blocking the pore formed by ROMK. And so when you have intracellular magnesium deficiency, right, magnesium deficiency, but intracellular magnesium deficiency more specifically, you get a more open ROMK channel. So you have a tendency to secrete more K into the urinary space. That is the explanation for why, it's often argued when you have a hypomagnesiemic, hypokalemic patient, focus on the magnesium deficiency so you're not chasing your tail with all the K supplement that you're giving. That's just dumping out into the urine. Okay. Polyuria itself, I already made this point, and so I'll just reinforce it, is a cause of urinary K wasting. Unlike sodium, you cannot render the urine's potassium to zero, essentially. And so when you have large urinary volumes, you will have obligatory K wasting. So that is one cause, interesting cause of urinary K loss, where the spot urinary K concentration, because they're polyuric, they have a huge urinary volume, may mislead you. It may lead you to conclude the kidneys are not responsible for this K deficiency, when in fact they are, simply by the total huge volume of urinary K of urine that they're making, which has obligatory K content in it. All right, we get to go through these disorders of hypokalemia with alkalosis and high blood pressure relatively quickly, because these are topics that should be familiar from our secondary hypertension conversation. Okay, so we have highlighted this physiology before quite extensively. I'll make the point quickly so that we can just pin our discussion that follows around this. The way that you secrete K is through increased apical membrane conductance. We've gone over that. But also by generating a lumen that's negatively charged. Usually that's done through absorbing urinary sodium via ENaC. Okay, so if I have hyperaldosteronism and I am able to reabsorb more sodium via ENaC because of that, I create a more lumen negative potential difference. The aldosterone binding its mineralocorticoid receptor also increases ROMK conductance. The net effect is high urinary K excretion rates, okay? High urinary losses. The hypertension arises because of the sodium avidity, right? So that's a classic primary hyperaldosteronism as one explanation for renal K loss. High aldosterone states, okay, include primary hyperaldosteronism and high aldo because of hyperreninemia, right? That's renal artery stenosis, hyperreninemia. If I have this very bizarre renin secreting tumor, classically it's from a head and neck tumor from a hemangioparasitoma that exists in the head and neck. The only reason I know that is because it's a favorite topic of Biff Palmer, brings it up. I've never seen a hemangioparasitoma secreting renin, but that is something that he often speaks about. But these are, in the book of causes of hypertensive renal K wasting syndromes with metabolic alkalosis. We've talked about these others, so I get to move quickly. Okay, I always remind the fellow, the name says it all. This is hyperaldosteronism, so aldos will be high. And when you give glucocorticoids to them, remember the pathophysiology? It downregulates ACTH. This is a syndrome in which ACTH is inappropriately driving aldosterone synthase because of an unequal crossing over event. It's a genetic disease, okay? Patients may have low aldo, but still be hypertensive when they have Little syndrome If you recall Little syndrome from prior conversations, that is an activating mutation in which ENaC is independent of aldosterone regulation, right? It's constitutively active. So these patients will have low aldo because ENaC is autonomous of the aldo, and they're hypertensive, volume expanded, so aldo is suppressed. Apparent mineralocorticoid excess, we've already gone over. That's the name says it all again. These don't have high aldo. It's apparent mineralocorticoid excess. The pathophysiology involves a defect in inactivation of cortisol. We've gone over that. Licorice is an acquired form in which this 11 beta hydroxysteroid dehydrogenase type 2 is inhibited by glycyrrhetinic acid in licorice or chewing tobacco products. Cushing's disease will just be cortisol, which is active at the mineralocorticoid receptor, not just aldosterone. And then we have certain congenital adrenal hyperplasias where DOAC, for instance, might activate the mineralocorticoid receptor. I'll just highlight once again what we've previously discussed, centered about steroid biosynthesis synthetic pathway, right? Sex steroids, aldosterone, and cortisol. So I get to, again, move quickly through those topics, unless there's a question that's slowing me down. Okay. I didn't give you much time to respond, though. All right, so let's talk about some of these others and finish this topic on dyskalemias and go on to acid base. We have hypokalemia from poorly resorbable anions. Remember again, K secretion revolves around the creation of a lumen negative potential difference. So if I have anions in the urinary lumen, then that would enhance K losses, right? So bicarbonate is one of those, right? And we explained where patients with NG suction, remember, we described how it's not the gastrointestinal K loss that causes hypokalemia in NG suction. It's the metabolic alkalosis and the filtered bicarbonate that obligates urinary K loss in NG suction. So NG suction is a classic question that comes up both in the bedside or in the real world, as well as on board exams. The urine or the kidneys are responsible for the bulk of the hypokalemia in NG suction. And that is because of urinary bicarbonate drawing K into the urinary space. Okay. Keto acids will do this as well. Salicylate toxicity, another anion that's filtered, will obligate urinary K losses. That often works against you. Okay. We'll get to that when I talk about acid base and salicylate toxicity and addressing that. But K deficiency often works against you in salicylate toxicity. So it is clinically relevant. Hippurate is toxicity is from toluene ingestion, the classic source of which is glue or paint thinner sniffing. And then this comes up on, again, Biff Palmer questions. I've never seen a case of clinically meaningful piperacillin-induced renal K wasting. We use a lot of Zosyn, and I have not seen a lot of urinary K or clinically significant K losses from all of the piperacillin that were given in our institution. But it has been described in the literature. These penicillins have a net negative charge. They are filtered by the kidney or eliminated by the kidney, both through secretion and filtration. And so they can theoretically increase urinary K loss as well. Okay, here we go. All right, so any questions about hypokalemia before we get on to acid base? No. Okay, so I'll just highlight that all of these parts of our discussion are summarized here. So let me see if there's anything that I didn't capture. Abiraterone therapy is an acquired form of congenital adrenal hyperplasia. We've gone over that as a cause of uh, secondary hypertension. It is a drug that inhibits 17 hydroxylase enzymes, so mimics a 17 alpha hydroxylase deficiency. I think the rest here we've covered. Okay. All right.